All right, everyone. Welcome and thank you for joining our Men's Health webinar. I'm your host, Carlos. We'll start with a few housekeeping items and then I'll introduce tonight's speaker. First, your participation in tonight's webinar is completely anonymous to other attendees. No one can see your face, your name, or hear you. If you wish to ask a question, please type it in the chat box at the lower part of your screen and we'll address these questions at the end of the presentation. Any comments or questions entered in the chat box can only be seen by our speaker and myself. Our presentation tonight will last for approximately 1 hour and we will be presented by Dr. Andino. Dr. Juan Jose Andino is a urologist who specializes in the evolution and management of men's health, sexual medicine, and male infertility. He is fellowship trained and completed his fellowship and subspecialty training in male reproductive medicine and surgery at UCLA. He is devoted to treating patients who are dealing with male infertility, erectile dysfunction after failing medications, and Peyronie's disease, to name a few. Beyond his clinical interests, Dr. Andino has developed his academic career by studying and advocating for telehealth as an option to improve convenience and access to care for patients. At UCLA Health, Dr. Andino is one of 4 inaugural Bruin Scholars who have been awarded funding for mentorship and research aimed at promoting the health system's commitment to continued improvement of justice, diversity, equity, and inclusion. This includes a dual appointment with Martin Luther King Jr. Community Healthcare, where Dr. Andino will be building a men's health program to ensure patients in South LA have equal access to specialty care for sexual and reproductive health. Dr. Andino, I'll turn it over to you to get us started.
Thank you, Carlos. And thank you, everyone, for spending some time with us this evening and for joining in for this webinar. Obviously, this is a topic that's a little taboo. Not all doctors, not even all urologists feel comfortable talking about it. And so I really appreciate this type of environment and setup where you can come in, be comfortable about it being an anonymous setting, but where you can really get the type of exposure that, to be very honest, sometimes we just don't have the time in clinic, to dedicate the amount of detail and attention that I'm going to be able to provide today through this approach. Carlos, thank you again for that introduction. Here is a little bit, basically in written form, a little bit of my background, what I do, my training, my residency training at the University of Michigan. My fellowship was here at UCLA, where I've had the pleasure of staying. And really importantly, I work out of a number of different clinics. So on the UCLA side, I spend time in Santa Monica, in Westwood, and I do a lot of telehealth because there's patients all throughout South and actually the entire state of California who have issues with sexual function and particularly erectile dysfunction, who may not have a local urologist who specializes in the advanced treatments, things beyond just pills. And I also spend time on Mondays. Every Monday, I'm at Martin Luther King Jr. Community Healthcare. I find that it's a very satisfying aspect of my job. I can kind of be a little bit more embedded in the community, an area where a lot of folks speak Spanish. I'm a native Spanish speaker. And so we can talk about these topics that, again, are kind of taboo. And if you don't have someone to develop a little bit of a connection with before being honest, it can be more challenging. So I'm going to start by sharing a little bit and being able to provide some teaching on just erectile dysfunction in general. And so what is it? It really refers to the inability to achieve or maintain an erection firm enough to have sexual intercourse. And I will add one thing to that definition. I'll add satisfactory, because there are patients for which penetrative activity is no longer a priority, but for the man, for the couple, for the patient that really wants to have a rigid erection that allows them to have penetration with a partner for their own and for their partner's pleasure, that to me is really what defines erectile dysfunction. And it is incredibly common. About 1 in 5 American men, 20 years or older, experience ED in their lifetime. More than half of men over 40 have some degree of ED. And ED seems to affect approximately 39 million American men, and that number has actually been rising. With the most recent census data, if we still estimate about 20% of all men are impacted by ED, that number has jumped up to almost 66 million. I don't have the graph here, but there's actually a nice chart in the urologic literature that shows that the numbers correlate by decade. So erectile dysfunction really is this condition that we see as impacted by health, but also can be a condition that's part of the male aging process, which hopefully makes it a little bit more comfortable and a little bit more natural to talk about. In general, 40% of men in their 40s will start to experience erectile dysfunction that will require some sort of treatment. And that goes up by 10% every 10 years. So by 60, age 60, 60% of men will be dealing with ED. By 80%. And so you can see something that becomes more and more common. And actually, we have an aging population in the United States, so that we know that we're going to need more and more experts that can go beyond just prescribing a pill like Viagra or Cialis. This is a picture, a cross-section of what the penis looks like in the flaccid or in the soft state. And then right next to it, you can see the erect state. So this is just an inside view of what you can notice when you're getting and maintaining an erection. There's this spongy tissue that almost looks like eyes. Hopefully you can see my mouse here. And what happens is that when the penis is in the soft state, that tissue is not filled with blood. And so it's smaller than when the penis is erect. When an erection begins, when there's stimulation, when there's foreplay, when there's that excitement, and a lot of those signals start up here in our brain, the blood vessels in the center of the penis here, they open up. There's called smooth muscle relaxation. And then the spongy tissue fills with blood. And that's what generates not only the length and the girth, but the rigidity of the erection. And actually, our body's very intelligently designed. So you can see these little blue veins. When that pressure builds up on the inside and the penis expands, it's actually that pressure that shuts off the veins so that you don't only get blood flow in, but it's actually maintained there in order to get and hold on to that erection. When orgasm happens, the body has signals that allows those smooth muscle in the vessels to shrink back down again, reducing the blood flow in. The pressure in that area goes down, and those veins open back up, and so the blood flow leaves the penis, and that's why after an orgasm, it is normal for the penis to get flaccid. And what are some of the causes and comorbidities associated with ED? Well, if you look at this graph, it's very obvious and evident that blood vessel issues, anything that's vascular in nature, makes up the vast majority of the causes of erectile dysfunction. Something that's been growing as well is diabetes. 30% of patients with ED have this impact from diabetes. And I think it's in a slide later on, but I'll go ahead and mention it now. Sometimes the first presenting symptom of diabetes can actually be erectile dysfunction, even before there are symptoms elsewhere. In about 15% of men, it may be related to different forms and different kinds of medications. And then some of the other causes include things like pelvic surgery, like a prostate cancer or bladder cancer surgery. But people often forget about the fact that radiation, chemotherapy, other treatments for cancer can also impact blood flow, can impact erectile function. And we know, regardless of what the cause is, ED can have a broad negative impact on health-related quality of life. So first, I'm going to spend a little bit of time talking about this relationship between erectile dysfunction and diabetes, because it has been a growing problem in the United States. In 2015, it was estimated that about 15 million men in the United States were being diagnosed with diabetes. And here are some of the things that directly relate to erectile function and erectile dysfunction, why we're having this talk. We know that patients with diabetes and erectile dysfunction are less responsive to oral treatments, so they may need some of these advanced treatment options that we have in the realm of urology that we're going to talk about more today. Men with diabetes will develop more severe erectile dysfunction, and this is associated with lower quality of life scores, lower satisfaction. And as I mentioned just before, in some patients, especially younger patients, actually ED or changes in orgasm, changes in ejaculation can be a presenting symptom of the condition, one of the first things that might be impacted by those high blood sugar levels. ED pills actually do require both stimulation, and so nerve signals to be carried down, as well as healthy blood vessels. And interestingly and importantly, ED can actually affect both. That's why men with, diabetes can affect both. That's why men with diabetes have higher risk of heart attacks or blood vessel problems that could cause strokes, is because we know that on the inside, it starts to affect the health of the blood vessels, but also diabetes affects the health of the nerves. So both nerve signaling and blood flow into the penis can be affected. And you can imagine that if both those things are being impacted, the pills which rely on those natural mechanisms are going to have a harder time achieving an appropriate and a satisfactory response. And in addition to just diabetes in general, we know that advancing age, just like with all men with ED, is going to be a risk factor. But how long someone has lived with diabetes? Is there poor glycemic control? Is there another factor? Do they have hypertension or lipid problems, cholesterol problems? Are they having heart issues? Are they requiring medications to get rid of excess fluid? And do they have any component of heart disease? And again, this really all comes back to the fact that you need both nerves and blood vessels to both initiate and maintain an erection. So let's turn gears here a little bit. And we talked about diabetes already. Well, what's another cause of potential erectile dysfunction? Heart disease or vascular disease. This is an incredibly important slide, and one thing that I think brings me and other folks who work in the sexual medicine aspect of urology a lot of satisfaction is that sometimes the thing that finally brings a man in to see a doctor to get evaluated is either a fertility problem or, like we're talking about today, a penis problem. They're no longer getting an erection. The erection is no longer as rigid as before. They can't maintain it. And this is really important because especially if the cause is a vascular one of erectile dysfunction, we know that ED can precede more severe cardiovascular disease, things like chest pain, having a mini stroke or a precursor to a stroke where the brain's not getting enough blood flow, or even having problems with blood flow to the legs, what's called peripheral vascular disease. ED may come before any of these other conditions take place. And why is that? Well, I think this picture is really worth 1,000 words. You can see the different sizes and the different diameters of the blood vessels throughout the body. And immediately you can see that the penile arteries, those that have to open up and bring in blood flow into the penis, are much, much smaller, 1 to 2 millimeters, much smaller than the blood vessels in the heart, much smaller than the blood vessels taking blood and oxygen to the brain, the carotids, and significantly smaller than the arteries taking blood flow to the legs. And so if all these conditions that are affected by the blood vessels, and men start to get symptoms when they're 50% obstructed, meaning half of that opening for the blood to flow through has been impacted by diabetes, lipids, blood pressure, etc., it makes sense that you're going to get erectile dysfunction symptoms earlier. Those are the smaller vessels. And then over time, these other systems, other parts of our body are going to be affected. So it is something that we think about, or we use the words risk reduction, because anything that improves your overall health and specifically your heart health can improve erectile function and can reduce the risk or reduce how quickly erectile function worsens. So these are things like thinking about our diet. If we think about more Mediterranean or vegetarian style diets, reducing fats, reducing a lot of grease in the food, avoiding fast food or processed foods, all these things can be potentially helpful. Exercise and physical activity. Anything that gets your heart rate up, particularly cardio-like exercises, improves blood flow not only to the heart, brain, and legs, but it also improves blood flow to the penis. Weight loss. We know that obesity, being overweight, can contribute to problems with the blood vessels, with the nerves, and even hormones, which we're going to talk about a little bit later. Smoking is horrible for our body, and primary care doctors always think about the lungs. Smoking is going to kill you. Please stop smoking. I have a little bit of a biased view, but I say not only can this hurt you years and years down the road, but this is hurting you right now. Your smoking is probably affecting the blood flow that you can get for the penis, affecting sexual function and affecting quality of life. Obviously, it's not easy to quit smoking, but it's probably one of the best things that a man can do for his sexual health, overall health, and long-term health. And stress reduction. This is something that's a little bit hard in the United States. We kind of have a busy, keep going mentality and attitude. That's why we're all here this evening, after hours, listening and learning. But things that can be done to reduce stress in the home, reduce stress at work, folks who engage in kind of mindfulness activities, use exercise as a way to de-stress, we know that that can also improve all these risk factors and make sexual health and overall health better. let me talk a little bit about that low testosterone that I just hinted at. Low testosterone can be a contributor to erectile dysfunction, but the other side of that coin is very much true, and I would actually say it's actually more commonly true. Many men will develop ED without necessarily having a hormonal or a low testosterone issue. And what does low testosterone really mean? Well, in our guidelines, it refers to a man who has a lab value. We've checked testosterone, that number is low, and just for a reference point, you can see that it's under 300. That's what's considered low by many of the medical standards, but they also have symptoms. They have low libido, low interest in sexual activity. Their energy, their mood, just they feel more fatigued. And then also they can start noticing that maybe they're not getting as many morning erections, or that when it's time for sexual activity, either solo or partnered, they're also having problems with their erectile function or not responding to pills for ED as well as before. It's much more common in men with obesity, men with diabetes, things that we've already been talking about, but also folks with high blood pressure, with high cholesterol, with asthma or COPD. So it can really be a quite common condition. And that's why me and other folks who specialize in this area will often check a testosterone level in that initial or the second visit that we have when we're talking about ED to make sure that there's not a modifiable or improvable factor. There's a lot of men who are estimated to have low testosterone. About 4 in 10 men, so 40% over the age of 45, may have low T and may meet this diagnosis or this criteria. And for every 10-year increase in age, we know that the incidence or the development of low testosterone increases by almost 20%. So just like erectile function in this bucket can worsen with age and time, testosterone levels is something that also we see as part of the male aging process. However, if they get low enough and they're causing symptoms, it's something that may warrant treatment and may benefit from treatment. When a man is diagnosed with low testosterone, treatment options may include testosterone gels, injections. Now, in the last few years, there's been oral medications, including some that can allow a man to preserve their fertility. And lastly, there are pellets that can be implanted in the buttocks to be able to slowly release that testosterone over a several-month period. This is an area that we see very commonly because urologists on both sides, on the oncology cancer side and the sexual medicine side, will work together to improve patient outcomes. But any sort of prostate cancer treatment, whether it's surgery, radiation, brachytherapy, the hormones, etc., can impact erectile dysfunction. And this is probably the best way to visualize it. If you see here, the prostate's in the center, it lives between the bladder and the sphincter. This is the tube that the urine would come out of where a man is peeing. Well, these yellow or beige structures are the nerves that travel next to, on top of, and around the prostate. And you can imagine that if that organ's being removed for cancer purposes, some of those nerves may be impacted. And if the cancer is severe enough, actually all the nerves may be impacted and they may have to be removed with the prostate. The sphincter, the urethra, and the bladder are connected back together, but you can see that those nerves have now been impacted. And so here are some of the numbers that put that visualization into perspective. ED, or sexual dysfunction after radical prostatectomy, affects about 1/4 to 3/4 of men after they've been treated. Even men who have a nerve-sparing robotic surgery, where the outcomes tend to be better, well, they may actually still develop erectile dysfunction, and it may take up to a year to see exactly where everything's going to settle out and even persist beyond that. And while I didn't have a separate slide, I did just want to take a moment to highlight that people always think about surgery as potentially impacting or causing ED, but men who have radiation for prostate cancer also do develop erectile dysfunction, and it affects about 50% of men who are treated not surgically, but with radiation. That area where the cancer will live is still going to be right next to those nerves. And so even though instead of being a knife or a blade or a scissor, they're getting radiation, that treatment effect will still have a negative impact on those nerves. There is this condition called Peyronie's disease. What does that mean? Many people have been seeing the bent carrot commercial, and that's a condition where most of the time, without knowing why, after sexual activity, there might be a minor trauma, a minor injury, but all of a sudden a man one day wakes up, they get an erection, or they get an erection prior to sexual activity, and they notice, what the heck? There's a curve there. I didn't have that before. They may also have a little bit of penile pain, some achiness, some discomfort. And it may be subtle at first, but over a period of weeks to months, that curvature can become pretty severe. I've seen penises just like this one on this slide, and even some that are worse. They're pointed straight up. You can imagine that some of the things that can occur when with this condition strikes is it can cause shortening of the penis, can cause narrowing, loss of girth, and most importantly, it can significantly impact quality of life by causing difficulty having penetrative sex. If the curve is severe enough, it's going to cause discomfort. It's going to make certain positions impossible. It may hurt you as the patient, or it may hurt a partner. And there are a number of treatment options out there. There are penile traction devices, and the best one is listed there for your reference, called the Restorex device. There are FDA-approved injections, something called Xiaflex. That's literally an enzyme that we target that plaque to try to break it up and soften it so we can restrain that penis. And then there's also surgeries for the cases that are severe enough. I want to take a moment to highlight that there are these other sexy, fancy sounding treatment options that get a lot of attention online or on radio or even ads on the internet. But there's shockwave treatments, there are stem cell therapies, and there's platelet-rich plasma therapies that had a lot of promise and have a lot of interest. And to be honest, they're still being studied, but so far the outcomes have not really shown a significant improvement in terms of clinical response. And in particular, the stem cell therapies and the platelet-rich plasma really has not been shown to improve Peyronie's disease or erectile dysfunction. There is some emerging data on the shockwave therapy, but what's challenging is to try to figure out who has an actual medical-grade shockwave machine and who's just putting the equivalent of an ultrasound on your penis, because those are two very different treatments and two very different outcomes. And so here are some of the treatment options that many men have heard about, or maybe not heard about. But really, when we think about urologic treatment of erectile dysfunction, these are all the things that we need to consider. Almost everyone knows about the pills, the little blue pill, sildenafil or Viagra, and some of the sister medications like Cialis. But I'm going to talk a little bit about some of these other options that are available to ensure that a man and a couple can restore intimacy. So thinking about the pills, how do they work? Well, the pills increase blood flow to the penis, but they actually require stimulation. You don't just take a pill and assume that an erection is just going to pop right back up. It requires mental stimulation. It requires manual oral stimulation. It requires foreplay, essentially. You can't just take it and sit there and watch a show and expect an erection to occur. And that also means that they require both blood flow to be intact and the nerves to be intact. So automatically, you can imagine that some of these folks who've had their nerves affected by either diabetes or prostate cancer surgery or something else where their nerves are being hurt, well, if the signal can't make it from the brain to the spine to the penis, even with taking the medication, they may not have an effect. In general, if we don't think about those other risk factors, 70% of men, especially at first, will respond to the pills. So they are a great option, and any primary care doctor should be able to start a man on these medications. But they do have side effects. Sometimes there can be headaches, there can be flushing. These things are not dangerous, but they can be bothersome. In other situations, some people can get a little bit of heartburn. And there are some situations in which we need to be cautious. If a man has had a heart attack, if a man is on any sort of nitroglycerin or nitrate type medication, that's the same part at the end of the commercial that you always hear. Taking this with a Viagra or Cialis can cause an unsafe drop in blood pressure. And so there really are situations in which it's a good idea to make sure that you talk to a doctor and not just get one of these pills from a pharmacy or online, because if you're taking something that could have a dangerous or negative interaction, it could have issues on your overall health. Importantly, about half of men with ED who start or begin their treatments with oral medications will eventually have to switch because they either have a side effect or the pills stop working and they have to think about these more advanced options. And really importantly, once again, just because it's becoming so common, that number is twice as high for men who have diabetes. They're much more likely to take these medications but fail either upfront or fail faster than folks who don't have that as a comorbidity or as a risk factor. There is a non-pharmaceutical treatment option for the person who says, I really do not like to take pills. I don't like medications unless absolutely necessary. There is something called the vacuum erection device. And you can see here, this pink thing is actually called a constriction band, and it works by physically creating a vacuum pulling blood flow into the penis. And then as you remove the device, you put a band at the base of the penis to help hold that blood flow. Effectiveness has been rated as quite high, sometimes in the 70, 80, on the best studies, 90%. And effectiveness really is defined by the ability to get blood flow in there and trap it with that band. But patient satisfaction is much, much lower. It takes a very specific person, a very specific couple to become comfortable with using the device, not feeling that it takes away from the episodes of intimacy. And really the continuity of these treatments are as low as 30 to 40% in some studies. The most common side effects you can imagine just from looking at that picture, a little bit of pain, a little bit of discomfort, sometimes from having that band on there while you're having sexual activity, there can be bruising and swelling. And certainly you never want to keep that band on for longer than 2 hours at a time. That could cause potentially permanent damage. And similarly, some folks will use metal versions of these devices. That's incredibly dangerous. And it can truly actually get stuck on the penis, requiring a trip to the emergency department. The most common reasons that these medications or that this device is not used long-term is the erection is still not rigid enough. So a person will stop it, and just discomfort. It gets painful, it gets uncomfortable, it gets awkward. Certainly, especially for folks who've had a prostatectomy, almost 90% of those patients move on from using the vacuum device because they don't find it to be satisfactory in the bedroom. I'm going to talk about this, but not go into as much detail as some of the other slides, because these urethral suppositories have really fallen out of favor. They have to be refrigerated. They're incredibly expensive, and only about 40% of time. So 2 in 5 guys, 4 in 10 guys will have a good enough response. And one of the medication side effects is that it can cause aching and burning of the penis itself. So low success rate, low satisfaction. There was a lot of interest initially because the thought would be that if you put the medication on the inside of the penis, it can get absorbed locally and have an effect faster than taking something by mouth, for instance. But really the data and the patient experiences haven't supported that. So most practices don't routinely offer this anymore. There is a gel that you folks have probably heard about that's going to be just directly applied to the penis, very similar mechanism. So it's going to be really interesting to look at, how that compares and whether people are going to use that before some of the oral pills when the erectile dysfunction is quite mild, or if it's going to be this in between from pills to injections to the surgeries that we're going to talk about. The intracavernosus injection therapy, ICI, it's what the acronym is you'll often see online, or penile injections. This works by putting medication directly into that part of the body where the blood vessels need to open up to create that pressure to shut off the veins. The effectiveness is incredibly high, 70 to 90%. And in fact, because you're putting the medication exactly where it needs to go to have its effect, instead of having to take it by mouth, wait for the nerves to send the signals, even in patients who have spinal cord injuries, who had prostate cancer surgery or radiation, so the nerves are not sending the signal at all, these medications will still work. The side effects that we worry about, however, it's of course a little bit of discomfort that might be felt when doing these injections. Folks who have a little bit of a tremor or who have a neuropathy, their nerves in their hands are starting to have issues, may have a hard time accurately giving themselves an injection, and that can cause swelling and bruising. And then the rarest thing, but the thing that we worry about the most, and why you should have teaching with a urologist before just doing this at home, is that if you get too much or too high of a dose to start, some people can get what's called a priapism, an erection that lasts more than 4 hours. And that truly becomes a medical emergency. Because if you don't relieve that pressure, if you don't get healthy, good blood flow with oxygen into the penis, you actually get death of the cells inside the penis, and that can permanently worsen erectile dysfunction to where it won't even respond to these injections. And then in that case, the only treatment is the penile implant surgery. The common reasons for discontinuation are things like cost, the process itself, because you have to have a refrigerator medication, get a syringe, get a needle, draw it up first, then inject it into the penis, and then wait 5 to 10 minutes. And so you can imagine just the workflow, the logistics of it for many people, or the cost aspect, because it's not covered by insurance, can become a barrier. And lastly, we get to the most effective treatment option, particularly for severe or advanced erectile dysfunction. This is the penile implant, and in particular, most of my slides today, I'm going to be focusing on the inflatable penile implant because it's considered the gold standard. How does it work? Well, let me go through the 3 pieces here with you. There's cylinders that go into the part of the penis where blood flow used to go, where that pressure used to build up, but it's no longer happening. Now we place these cylinders in this area. Importantly, we don't resect, we don't cut out any tissue, but rather we gently place these cylinders and they are matched to size. So during the surgery, we make measurements on the inside of the body so that we know the exact length from the skin to the tip, as well as the part of the penis that's actually inside of the body that we can't see or feel. And so every single implant is measured so that it's the maximum size available for that patient. Then we have what's called a reservoir or a balloon. And what this will have is sterile fluid, sterile saline. And that is what the pump helps move from the balloon to those cylinders so that as you pump it up, you're generating rigidity and getting to the point of a tough, rigid erection that can allow for penetrative sexual activity. There's also a easy to feel button on that pump that when you're satisfied with sexual activity, your partner is satisfied, you press that button and it deflates. So you heard that right. You actually are able to orgasm, ejaculate if ejaculation is still there, but still maintain that erection if that's something that you and a partner are interested in. The effectiveness is incredibly high. For patients themselves, 98% are satisfied with these devices because they finally not only have the rigidity and ability to have penetrative intercourse, but something that kind of puts the control and puts the power completely back into their hands. That's to say they go into the bedroom, they can pump this device up themselves. They don't have to worry about taking a medication an hour prior, doing an injection 15 minutes prior to sexual activity. It does seem to really restore this ability to control when intimacy happens and for how long. And the most common side effects or complications or things that I think about can be swelling and bruising after surgery. Certainly, initially, there's going to be a little bit of discomfort, but actually it's a lot milder than people expect. And it's actually quite rare nowadays to even require narcotic type pain medications for these types of procedures. What is the rarest thing, but the thing that we worry about the most is infection. Historically, and the reason a lot of primary care doctors and other folks who don't specialize in this area fear or have misconceptions about the implant is that for the longest time, infection was the most devastating complication of getting one of these devices. When a device in the body, whether it's a penis implant, a hip implant, a knee implant, any implant that's placed in the body that provides function, if it gets infected, the challenge is that just antibiotics, whether by pill or by IV, they can't fully treat or clear that infection. The bacteria basically make a home on the device, and the antibiotic can't penetrate that home. And so really the treatment has to be to remove everything. Because of the design provided by these companies, and specifically the Boston Scientific device, which is what we're looking at here, it's actually impregnated or filled with antibiotic in the device itself already. And that, plus a number of other things that we do before, during, and after the operating room, has really dropped the infectious risk to about 1 to 2% around the country. Internally, when we've looked at our data, it's been closer to the 1%, which we're very happy about. Lastly, it is a device. It's got tubes, it's got a pump, it's got connections. There can be mechanical failure. But as you can see from this slide, at 7 years, 98% of these devices are fully functional. And there are folks who have these for 10, for 15. I think the record that I've seen to date is somebody who had an implant placed 25 years ago, and it was still functioning until quite recently. This is the most implanted device. And like I said, it is the only one that has a built-in antibiotic treatment option. We, I believe, hit the 50-year anniversary, actually, of penile implants being available in the market just in the last year. And more than 500,000 men have received these devices. But we know that there's a huge gap between the folks who are treated with pills and those who actually have the luxury and option to even think about this as something that can be done for themselves and for their partners, because there's a lot of misinformation and there's a lot of lack of information where people are never even told that there's options beyond just your typical pharmacological treatments like Viagra, Cialis. Let me see if I get a chance to play this video here. And this really just highlights how the device itself works, and in particular, how it goes from a natural appearing flaccid or soft state to a pumped up rigid device that allows for penetrative and satisfactory sexual activity. So what the patient is doing there, he's pumping up. The bottom part of that pump moves the device from the balloon to the cylinders. You can see a rigid erection is generated. And then after sexual activity, press the deflate button and that fluid will go from the cylinders back to the reservoir. So everything's recycled. And that's what also contributes to the longevity or long-term use of this device, is that it's a closed circuit, a closed system. Let's see, we have one more video, or this might be a duplicate. Yep. And so what should you expect for the procedure? If you're someone who's thinking about the penile implant surgery, either pills are failing or have failed, or you have a side effect, or you can't take them because you have nitroglycerin for your heart, you've tried injections, or just the idea of putting a needle in the penis, the process, the cost associated are going to be a barrier. You've been thinking about it, but you just really wanted an opportunity to hear in a safe environment kind of what it's like, what the expectations are, what the risks are, et cetera. Here are some of the things to think about in terms of the actual logistics of how I do the procedure, what the recovery is like, et cetera. It's usually performed in our outpatient surgery center, except for our patients who have some cardio or pulmonary issues that require it to be done in the main OR anesthesia. I often do it as an overnight admission, primarily for the convenience of patients and their partners or whoever's picking them up. You have a Foley catheter when you first wake up from the procedure, draining the bladder. We have a special dressing. We have a drain that helps suck fluid out of the scrotum to reduce some of the swelling that happens post-operatively. When folks are able to stay the night, all of that gets removed the next morning, and it really removes any need for any sort of specialized wound care at home. It can be done outpatient. So people who are local, whether in South LA or here up on the Westwood, West LA, Santa Monica area, folks who are local are able to go home the same day, and they could just come to clinic the next morning and get all of that removed as well. So I'm very open to both options, unless there's a medical issue for which I say, hey, we really should keep you overnight to keep an eye on your blood pressure or heart rate, et cetera. I do it through a small incision through the scrotum, something called the penoscrotal approach. It's about this wide, horizontal, so a straight line across the scrotum. So when it heals in really nicely, and you can barely see the scar. And overwhelmingly, for the vast majority of patients, we can put all the components through that one incision. There are situations either due to previous surgery, radiation, and extremely rarely just by chance. During the operating room, I take a feel at the area where I'm able to put that balloon with the fluid, and there's scar tissue or other organs there in the way that could be dangerous. There's also situations that are the minority of the time, but where we actually put in the balloon reservoir through a separate incision, something called a counter incision. Generally, within a few days, you're almost back to your regular routine. We definitely say light activity, at least for the first 2 weeks after the procedure. So that means not lifting more than 20, 25 pounds, not doing any crunches, anything where you're really activating those core muscles. And then on average, by about a month out from surgery, sometimes 6 weeks, depending on the tenderness and the swelling, that's when most folks are able to inflate, deflate the device, and go home ready to engage in penetrative sexual activity. And cost and coverage, of course, is always top of mind. It's just something that we have to deal with in the US healthcare system. Thankfully, as opposed to almost everything else between the pills and the surgery, most commercial insurance, so insurance that you get through your work, Medicare, and even some Medicare Advantage, do have some component of coverage, and specifically for the inflatable penile implant. It does vary, and we have to look at that ahead of time, because I never want anyone to have a surprise bill, but that in general, we have better luck with insurance coverage for the surgery than we do for injections, for the vacuum device, and even back in the day when folks were using the suppositories. I have to acknowledge for this group tonight that in the Medi-Cal Medicaid setting, it's a little bit more challenging. Sometimes the inflatable device itself is just not covered at all. And sometimes we have to talk about another option called a malleable implant. And that can sometimes, there can be medical reasons why that one is required, but that is a cost consideration. Importantly, just like this slide says, this is a situation in which you really need to engage with a specialist myself or someone like me in the area near you who focuses on doing these surgeries and not only does 1 or 2 of them a year, so that they have a team built into evaluating these insurance benefits and making sure that they can fight for you to try as hard as possible to get the coverage. And you can imagine that in the long term, there can be significant cost savings. In fact, at the most recent Sexual Medicine Society meeting last November here in San Diego, I think when they looked at 3 and 5 year costs of pills and injections compared to getting an implant, the saving was often in the thousands and thousands of dollars, just because this is a one-time thing that can be covered. And then moving forward, you can expect 7 to 10 to 15 years of shelf life for the device and activity. And what are some of the benefits? It's proven 97, 98% patient satisfaction. Importantly, partner satisfaction is incredibly high. It would be frustrating to get a device that then a partner says, well, I'm not enjoying this intimacy compared to before. But we see that the 3 Ps, the inflatable implant, really does have high patient and partner satisfaction. Unlike 10, 15 years ago, now the risk of infection by coating the device with antibiotics and a number of other things that I do as a surgeon before, during, and after surgery has dropped the infection rate significantly. We have better coverage now with insurance, certainly better than a lot of the other treatment options for erectile dysfunction. And it's very long lasting. It's concealed, it's permanent until there's a mechanical failure. And while at 7 years, 94% are still in use, at 10, 89% are still in use. And like I said, it's a curve. There are folks who are way on the far side that can keep their device active and satisfied for much longer. Really importantly, this particular device, the inflatable one, is designed to maintain a natural appearance in the flaccid state when the penis is soft, but then generate that rigidity and that erection to allow for penetration when it's time for sexual activity. And spontaneity is one of the things that most patients breathe a sigh of relief when they undergo surgery and they're finally to the point of inflating, deflating, and using the device. As they tell us and they share with me, I didn't realize how much mental energy it was taking to have to plan out when I took these pills, to have to plan out when I got my next set of injections, and oh, I forgot to put it in the fridge. Is the medication going to go bad? So when we reach this stage, it is an elective procedure, but it can truly be a life-changing and a life-improving intervention. Oh, it looks like the slide here got offset a little bit. Let me see if I can fix that while I have you folks here so we can make sure that we can see that perfectly. Good. Awesome. I think I was able to do a little bit of troubleshooting. There we go. So there are risks involved with every surgery. Apologies for that. A little technical, dealing with Zoom and PowerPoint in the middle of our webinar. But like with everything, I started by highlighting all the benefits, all the reasons why patients undergo this surgery, seek out this surgery, and are eventually satisfied with this surgery. But with any surgery, there are risks. And so it is really important to talk about that and to have a very informed discussion. And hopefully this is just the beginning up front. It's not all patients are a candidate for an inflatable penile implant. There are some folks who would benefit or require that malleable one. It's actually just one device. It's very rigid and stiff and stable at the base, and then it has a malleable or bendable component. There's no pump, there's no tubing, there's no fluid. Certainly for someone who has difficulty with their hands, with their nerves, who wouldn't be able to pump up the device, or who has significant surgical and scar tissue from radiation where it may be dangerous to place a device, we might have a plan B. But there are other risks that are important to consider in these situations. Once you have an implant, it is really going to be a permanent change and a permanent solution, meaning that if there's any issue, whether infectious, mechanical, etc., and the device has to come out, there's not going to be any spontaneous return of erections. That's why many patients go through pills, go through injections, go through some of the treatment options to ultimately consider the implant, because when we make this decision, we really do know that it will have a permanent effect. And oftentimes that satisfaction rate of 98% makes it quite worth it. But it is important to know that there is an issue. What may be required is actually dealing with the problem, an infection, a mechanical failure, etc., But if a man and their partner still desire intimacy and sexual activity, oftentimes it means a revision. They're going to need a new device in the future if they want to get those erections again and be sexually active. Pain is certainly something that we can see in achiness at the very initial period when the body's healing, especially because for the first couple of weeks, we actually leave the device partially inflated so that the body doesn't generate scar tissue that could cause penile shortening. But this, like I said, is often something that can be treated with Tylenol, with a prescription strength version of ibuprofen or Motrin, and very, very rarely, except for people who have allergies or some chronic pain problems, does it require short-term few days of narcotic or opioid type pain medications. Men with diabetes, with spinal cord injuries, who've required radiation, they're going to be at a higher risk of infection. And that's an important, consideration and important discussion to have up front. And sometimes we look at things that can potentially be improved. Like if the blood sugar numbers are too high, well, actually, we're going to have to get those down before we go forward with this elective surgery to give you the best shot of having a successful first surgery and a satisfactory outcome. And like I've said multiple times around the country, the infectious rates are really in the 1 to 2%, 1 to 2.5%. But thankfully, at our division and me and my partners, because we focus on prosthetics and doing these surgeries, we have procedures and protocols in place that seem to have dropped that to closer to the 1% range, never down to 0, unfortunately. In summary, ED is an incredibly common problem. It's associated with a number of other medical conditions and often ones that we hope to improve because they can improve overall health and longevity. There's a number of treatment options. The most basic ones can start with your primary care doctor. Pills, Viagra, Cialis. That's something that any doc that you're seeing, especially in the primary care setting, would be able to provide to see how the body's responding. But I really think it's critical for patients to be empowered and know that there are things beyond that, because it is common for those to eventually fail and for people to look at other options if penetration, if sexual activity is important to them. And lastly, penile implants can offer a long-lasting and satisfactory solution, especially for the most severe or the most advanced forms of erectile dysfunction. I'm going to leave this slide up for a few moments here. If you text ED Cure to 73771, this will allow you to receive some additional informational videos to talk a little bit more about, go into more depth into the topics that I've discussed today. Similarly, you can take a picture of this QR code, and that will take you to this fantastic website. And I think what I love the most about it, and what my patients have told me they love the most about it, is that it's really designed and curated for it to be digestible and patient-friendly. Meaning there's a lot of testimonials, a lot of people sharing not just the science and the statistics and the surgical side of things like I talked about today, but what are people's experiences? What led them to the point that they sought out a penile implant? How'd they feel during, after, while they were recovering, while they were learning to use a device? So it really is an incredible resource, and I encourage you to take a look at it and look at the different segments in there. And there's actually a lot of patient and couple videos where real patients are being interviewed on how this improved and kind of changed their life for the better. And finally, I'm going to leave this slide here. Thank you all very much for your time, for your attention. I want to make sure that we have a little bit of time saved for questions.